All right, here we go again. Liver part two. I feel like we could probably spend a whole month on the liver. It is the most intimidating chapter that you guys are going to go through. And we're just like going to have to work together, and you're ask me questions if you're having trouble understanding it, like start scanning in your lab. And this is all going to be stuff that's going to help you kind of get it. Again, this is a lot of information. And I'm going to really like try to tell you what you really need to know at this time in your like class. Verse when you do your registry, when you're out of school, you're going to just have all that clinical experience. You're going to keep on learning. And a lot of this stuff you will study again. But just to get you going, I'm going to just touch up on the stuff that we need to learn now. So let's talk about hepatic change, hemodynamic changes, vascular abnormalities, and the normal hepatic vascular flow. So Doppler scanning is really important when we are looking at the liver. We always want to put color on the portal vein, and the reason why, you remember, is what we talked about last week. We want to see which way the blood is flowing in, because that kind of determines if the liver is healthy or not. If it's going towards, which it should, it's called hepatopetal flow. If it's going away, it's called hepatofugal flow, and that can indicate some disease. It's also very helpful with hepatic arteries and hepatic veins. I always put blood flow on the hepatic veins in that bunny sign, the Playboy bunny sign, up at the transverse superior liver. Okay, so let's look at normal flow here. So the red is towards when you're scanning. And as you're starting to scan the liver, I want you to practice seeing if you can see the blood flow on your classmates going towards the liver. This is called hepatopetal flow. So in a Doppler ultrasound, what you're going to know, when it's red, it means it's going towards the transducer. When it's blue, it means it's going away from the transducer. So red is obviously the transducer is up at the top here, in the anterior liver. And so the blood flow is going towards the transducer. So it's going to appear red. Here's another image of it. With the portal vein, it's not going to be a like arterial flow like we would see in the aorta, or like a artery in the leg. It's not going to have that high resistance flow like da 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 da. It's going to be more continuous, because it's a vein, and it's constantly bringing in blood flow. So it's going to look more like a just constant flow above the baseline. The veins here, you can see they have blue flow, and that's totally normal for the hepatic veins. You want hepatofugal flow for the veins. Sorry, I'm in my office and I've just got a phone call and I don't know how to stop it. My apologies. We're going to work through that. So hepatofugal flow is going to look like this. Again, it's blue is away from the liver. And it has like a triphasic flow pattern. Hepatic venous outflow obstruction, Budd-Chiari syndrome, is an uncommon condition of the hepatic venous outflow obstruction. So it can occur at any level. It can occur in the small hepatic veins, the main hepatic veins, at the junction of IVC and right atrium. So it's clinically significant because it generally requires occlusion of at least two hepatic veins. So some of the clinical features of this are abdominal pain, jaundice, ascites, hepatomegaly, and splenomegaly. So the liver and the spleen are going to be enlarged. They're also going to have jaundice and ascites. So what are you going to see? You're going to see like the veins occluded. So you won't see that nice blue flow that you usually see in a healthy liver. The classical acute presentation is going to be the triad of ascites, hepatomegaly, and abdominal pain. So there's multiple reasons why you could have a thrombosis in your hepatic vein. One of the interesting ones that could um, occur in young girls is oral contraceptive use. A tumor invasion from a hepatocellular carcinoma, a renal or adrenal carcinoma, severe liver metastatic disease, a Wilms tumor in pediatrics, or radiation to the liver. And sonographic findings depend on the degree of venous or obstruction or underlying flow. So you're going to see like hepatic veins not being visible, narrow or reverse flow. Grayscale imaging, which is without color flow, is going to, you're going to have hypertrophy, which is enlargement of the caudate lobe as the liver directs its venous blood to caudate lobe to direct venous drainage into the IVC, because our bodies are super smart. And so if we're not getting blood flow, the body is going to make a way. That's exactly like I talked about, like with the cirrhosis. Different veins that were fetal veins that are now ligaments are going to open up. The body is going to create collaterals, because it's like, we got to get this blood flow through here fast because we got to survive. Other findings would probably be portal hypertension, intrahepatic venous collaterals, ascites, splenomegaly, flow disturbances, the IVC, and thrombus extending into the IVC. Passive liver edema secondary to vascular congestion is a complication related to heart failure. So that's just what I want you to just know the definition on that. And you can go through that on your PowerPoint. Look how big the IVC and the veins are with this. And with passive liver congestion, you're going to get like the moose sign, because doesn't that look like a moose? If it doesn't look like a Playboy bunny and it looks more like a moose, it's probably passive liver congestion. Okay, I think I'm going to stop on that because I want to really concentrate on our cyst. But first, our quiz. What term defines blood flow towards the liver? We just talked about this. Remember what we're thinking. And if you said C, hepatopedal, you are correct, because we're going to pedal towards the liver. So the portal vein has hepatopedal flow in a healthy liver. Which statement is true regarding Budd-Chiari syndrome? The caudate lobe and veins appear deteriorated. That's not true. The obstruction of the venous outflow is a common condition. The clinical triad includes ascites, hemorrhage, and discomfort, and generally requires obstruction of 2 hepatic veins to be clinically significant. If you said D, you are correct. The clinical triad that is going to be occurring is ascites, hepatomegaly, and abdominal pain. Okay, let's do this one. Which sign describes the sonographic appearance associated with dilatation of the inferior vena cava and hepatic veins from right heart failure? If you said Canadian moose, you are correct. Some like sonographic, like little funny things, I'm like, I really can't see it, but that moose just stood out to me pretty good. So that should be something that you are able to really like remember. Okay, what I love learning about cysts. I don't know why. I think they're just easy. So I want to spend some time on these. So there's congenital or there's acquired. So congenital cysts are true hepatic cysts. They're categorized as simple cysts or related to hereditary disorders such as polycystic liver disease. They result from development anomalies in formation of intrahepatic bile ducts, proper involution of the ductals, or both, and incident increases with age. So if you guys remember what our simple cyst looks like, it's going to have regular, like very defined borders. So it's not going to be irregular. It's going to be anechoic. It's not going to have a lot of internal echoes. And there's going to be acoustic enhancement. Acquired cystic lesions can result from trauma, parasites, or inflammatory reactions. So congenital cysts are usually asymptomatic and usually discovered incidentally in like 1% of patients less than 60 years old, but 3 to 7% of older patients. So it might be common for you to see a cyst. Solitary lesions are more common than multiple cysts. So you might just see like a little cyst in the right lobe. They can be big or small, and they can cause hepatomegaly, palpable nodules, abdominal discomfort, or rarely localized bile duct compression. Sonography is the imaging modality of choice, especially with cysts. Sonography can diagnose like a complex versus simple cysts very good. So if you saw a cyst, what would you say? You would say simple cyst seen measuring 3 by 3 centimeters in the right lower lobe of the liver. No vascular flow is seen within this cyst. If they get really big, they can be aspirated with a fine needle, and they should contain clear fluid. With congenital cysts. Two forms of polycystic liver disease. There's isolated polycystic liver disease where like poly means a lot, so a lot of cysts in your liver. Or there's polycystic kidney disease, which we're going to learn a lot about in OB/GYN2 next semester, because some polycystic kidney diseases can be fatal in fetuses, but there is one called autosomal dominant polycystic kidney disease, which patients can survive, and they end up having cysts in both their kidneys and their liver. So these are some cysts. These are just like you see like one big cyst and then 2 little cysts. This is a simple cyst. Sometimes you'll have reverberation artifact. This is not internal echoes. This is just reverberation. So you can use your TGCs to kind of clean that out so it looks more anechoic. Look at all of these cysts. This is a patient with polycystic kidney disease. Polycystic liver disease, excuse me. Now, do you have to measure all of these cysts? Absolutely not. Oh my gosh, you would be scanning for like 3 or 4 hours if you did this. But I would pick like the 3 largest. That's kind of like my rule. Pick the 3 largest, like fibroids, 3 largest of anything, and measure them and let them know. But say multiple cysts seen within the liver. So acquired cysts are categorized as traumatic, hematoma or biloma, parasitic, or inflammatory from an abscess. Patients are usually asymptomatic with this, especially with the parasitic or inflammatory abscess, are going to be sick. So localize, measure, characterize appearance of acquired cysts. That's what you need to do. Localize, measure, characterize. I had a bag that said, what did it say? It was so cute. It said, see it, measure it, put some color on it, done. Because I think that's really what you have to think of when you think of ultrasound, you know, because we're learning all of this different pathology, but it doesn't mean that you're going to be diagnosing there. You're going to maybe kind of know and know what to look for, but you don't have to put possible like parasitic, you know, cyst. You say what you see, and then you leave it to the doctor to diagnose. That's their job. They went to school for a long time to do that. So a hematoma can be from trauma, secondary to interventional procedures, hepatic artery aneurysm, or associated with pregnancy-induced hypertension. Symptomatically, the liver is super tender, significant bleed. Patient may physically collapse and show signs of shock as blood pressure, pulse rate decrease, and hematocrit levels drop. So liver trauma is really serious. CT is the imaging modality for blunt abdominal trauma. So I always thought these were kind of gross, but I'm interested in them. But then I'm like, oh my gosh, hydatid diseases, acquired cyst. The most common are these two, parasitic tapeworms. If larvae invaginate and develop, they become encysted and generations of daughter cysts develop. So original unilocular looking cyst is eventually filled by multiple cysts of varying sizes. Sonographic appearance depends on the larval maturation. Possibilities include solitary cyst, mother cyst containing internal peripheral daughter cysts, fluid collections with septa, a honeycomb appearance, or solid looking cysts. This is showing like a hematoma, subscapular. Okay, parasites like usually happen um like more in developing countries, it seems like, or if you've gone over to a developing country, you have a higher chance of that. So a patient from Kenya presents with right upper quadrant pain and hepatomegaly. Sonography demonstrated a large cyst with daughter cyst compatible with an echinoccal cyst. Another patient with an echinoccal cyst that's solid and has rim calcification. So they can be different, look different on sonogram. So which of the following is a true hepatic cyst? Acquired, congenital, hematoma, or hydatid disease? You said B, you're correct. True hepatic cysts are congenital and further categorized as simple cysts or related to hereditary disorders such as polycystic liver disease. Which imaging modality has 95% to 100% accuracy in diagnosing hepatic cysts? If you said sonography, you are correct. We can really do that really well. What is the most common occurring polycystic liver disease? Autosomal dominant polycystic kidney disease is the more common polycystic liver disease. So A. We're going to go to hepatic abscesses. Talk about amoebas. Patients, any kind of abscess, patients do not feel good, and they're going to like present with pain, fever, elevated white blood cell counts, leukocytosis. So sonography can locate, measure, and characterize hepatic masses, usually due to bacterial parasitic infections. And sonography can be used to guide aspirations for cultures. A pyogenic abscess is almost 80% of hepatic abscesses. E. coli is the most common isolated organism. And biliary tract disease is the most common source. So bile flow obstruction allows bacteria to grow and proliferate and can produce multiple abscesses. So pyogenic bacteria enter the liver via portal vein or hepatic arteries. So can you imagine like the liver, it like helps filter out. It's such an important organ for us. And then when it's sick with an abscess, like, can you imagine how bad you would feel? You would definitely have a fever. You would definitely like just feel like super sick. You probably have right upper quadrant pain. So the symptoms are depend on severity and extent. You're going to have fever, leukocytosis, elevated LFTs, liver function tests values, right upper quadrant, pleuritic pain, and hepatomegaly. Single or multiple masses, 1 centimeter or larger, 80%, and the right lobe. And they can be variable shape. They can be round, poorly defined, irregular walls. They're usually less echogenic than the hepatic parenchyma, so they can be hypoechoic. I think the only way that you can really know is by a biopsy, though. But look at this one. It just doesn't look good, you know? So the sagittal scan of the patient with debris-filled pyogenic liver abscess. Note the acoustic enhancement that helped differentiate this from a solid mass. So always look for that brightness underneath. And large liver abscess in a patient with cholecystitis. So they're getting hit by both things. Their gallbladder is inflamed and then they have this huge abscess in their liver. So you see this, and then you're like, is it like cancer or is it like abscess or is it, something else we've learned? But let's look at like the clinical symptoms of the patient. And that's going to help us really determine, because if the patient's really sick with what we've talked about, like the symptoms, then they're going to probably lean to more of like an abscess or some kind of infection. A pyogenic abscess, patient presented with pain, fever, history of diverticulitis. Sonogram shows complex collection in left liver lobe compatible with an abscess. The gas is the echogenic little areas that are on the arrows there. This type of abscess is associated with high mortality rate. Okay, amoebic abscess occurs when patients is infected with parasite from contaminated food and water. Blood may carry parasite via portal. Humans are the intermediate host and usually asymptomatic when the organism is confined to the GI tract. Ugh. Developed abscess is right upper quadrant pain, reactive hepatomegaly, diarrhea, fever, chills, jaundice, black tarry stool, and moderate leukocytosis, mild anemia, and elevated LFTs. Usually it seems like the right lobe is more affected by all this stuff. And this might be because of the superior mesenteric vein that drains from the bowel that goes into the liver. Here is a parasitic cyst who lived for a time in Indonesia. So which type of hepatic abscess usually develops when the reticuloendothelial system is compromised? If you said B, you are correct, pyogenic. Which choice explains why an amoebic abscess is more likely going to affect the right versus the left liver? I just talked about this, so hope we're learning. So it's A, the superior mesenteric vein is supplied by the portal, or the SMV supplies the portal vein. SMV is drained from the GI tract. So if there was some kind of amoebic vein in the GI tract, it's getting transported to there. Gross. Goodness. A couple more parasitic infections to talk about. And I'm going to probably stop and let you guys well, I'm not stopping yet, so don't get excited. But these two right here, I'm going to have you look at by yourselves because this is going to be like 2 hours if we do keep doing that. Okay. Anyway, schistosomiasis. Hi, geez, I am sorry. Some of these words, even I can't say, man. Okay, so common parasitic infection in Africa, Asia, Indonesia, China, Japan, South America, and Mediterranean. Contaminated water with immature worms can penetrate skin and travel via lymphatics and bloodstream to the mesenteric veins. Okay, we know that. Eggs can travel to the intestine, urinary bladder, migrate up to the portal vein. Ova penetrate portal venous walls, lodge in surrounding liver tissue. Yeah, causes fibrosis. After a long time, portal hypertension may develop and cirrhosis is possible. Portal hypertension, splenomegaly, gastroesophageal varices, hematomas, and ascites. Hepatic function is commonly preserved until late disease stages. So sonographic features of this, I would say irregular hepatic surface, hypercoic thickened walls, given a clay pipe stem pattern of the periportal fibrosis and splenomegaly with portal vein and splenic vein dilatation. So just remember this one when you see this on the registry. Oh yeah, this is the one that our instructor couldn't pronounce. If you see all these like lines, it looks like fibrosis, right? Like it doesn't look like a pretty little liver. It looks like lines separating the liver. This is this thing. So a 30-year-old woman with right back pain, a calcification noted on a non-contrast abdominal radiograph, and patient referred for a renal sonogram evaluation. So sagittal A and transverse B sonograms deliver advanced periportal fibrosis, provides the turtleback sonographic appearance. So turtleback, it kind of looks like a turtle, I guess. Not as good as the moose, but I can see how it kind of like could look like what a turtle looks like. I mean, you got to use your imagination. Patients that have HIV and AIDS have a higher chance of having a lot of different liver issues because their immune system is so down. Pneumocytosis, Jerveci, I believe, is the most common opportunistic infection of the HIV infected persons. Majority of AIDS infected people eventually develop pneumocytosis pneumonia, and it gives the starry sky pattern. Now, I would just want you to know for this that, a patient with HIV or AIDS has a higher chance for a lot of different infections. One of the most common masses in the liver with HIV and AIDS is Kaposi's sarcoma. Again, there's no way exactly to know that, but it's not uncommon to see a patient that could present with a mass and have known AIDS, and it's probably this Kaposi sarcoma. Look at this. This is starry sky. And this patient has a pneumocytitis. Oh my gosh. Pneumocystis. It's been a long week, okay, guys? Pneumocystis, I don't know. Okay, anyway. If you're listening to me, I hope you're smiling through all this. So they have pneumonia, basically, from this infection. This little mass that can be difficult to see is Kaposi sarcoma. But the only reason they really knew that was because it was a biopsy and they saw that there's a little mass there. Do you see how indistinct that is? They can also get a fungal infection. So other parasitic and infectious processes. I had a little computer issue for a second, so I apologize. Fungal infection, hepatic candidiasis, liver complication, and HIV or other immunocompromised patients. So mycotic infections can cause hepatomegaly and microabscesses. This lesion usually displays a wheal within a wheal imaging pattern, so I want you to know that. The outer hypoechoic wheal represents fibrosis surrounding the inner echogenic wheal of the inflammatory cells and a central hypoechoic area of necrosis. This is a patient that was immunocompromised because of chemotherapy. Patient presented with fever, although metastatic disease could have similar appearance. Which parasitic or infectious processes can occur when immature worms from contaminated water penetrate the skin and travel by way of the lymphatic or blood system, bloodstream to the mesenteric veins? It's, of course, the one that I can't pronounce. Schistosomiasis is what I'm going to say. Which term best describes when sonography demonstrates a diffuse pattern of numerous tiny, brightly reflected parenchymal echoes? If you said starry sky pattern, you are correct. Let's do some benign neoplasms. Okay, these are the ones you're going to see, and I like learn about these. I've decided I didn't like that last one. So cavernous hemangioma is the most common benign liver tumor and occurs in up to 4% of the general population. This one, let's know this one, okay, guys? Let's know this. Hemangiomas are 5 times more common in women. Know that. They can occur at any age, but increase in frequency with age. And most hemangiomas are asymptomatic and found incidentally. Most are solitary, but 10% to 20% of patients can have multiple hemangiomas. Typically measure less than 3 centimeters, but larger lesions known as giant hemangiomas are possible. Location is usually in the posterior segment of the right lobe or in the subcapsular locations along the periphery of the liver. Sonography is reported to be more reliable than CT in detecting cavernous hemangiomas, especially those smaller than 1 centimeter. There's not going to be any flow in these, so no vascular flow. These are what they look like, and I see these all the time. They're like brighter, more echogenic, circular most of the time, and no vascular flow. So if I put a picture of one of these on your test, you will be able to tell me what you think it might be. Look at, there's no vascular flow within there. Look at that one. And that's in the posterior right lobe. This is a giant hemangioma, so this would be greater than 3 centimeters. Okay, so we know about what that is now. So we feel good about that. Let's talk about focal nodular hyperplasia, and it's the second most common benign liver mass. So first is the hemangioma, and this is the second one, so you need to know this one. And it contains all the cellular elements of a normal hepatocyte, but it lacks the normal hepatic architecture. Arterial supply is to the mass of the hepatic artery. No portal venous branch, and hyperplastic condition may occur at any age, but is rare in children. More common in women, particularly in childbearing years. So I think like the 2 top masses are more common in women. So let's think about that. Now this one has a evidence of a relationship with long-term use of oral contraceptives. So OCPs can be great, but it seems like they can cause some liver issues too, right? Usually asymptomatic. It can be subtle isochoic lesion, difficult to identify with a normal liver parenchyma. And the mass is well circumscribed. The color Doppler may demonstrate blood flow from feeding vessel in the center of the lesion, and usually 5 centimeters, but can range from 0.5 to 20 centimeters. That'd be pretty large. Here is what it looks like. So our hemangioma was bright and echogenic, and the foveolar nodular hyperplasia is more hypoechoic, right? But you can see the borders of it pretty easy. Liver cell adenoma is differs from the foveolar nodular hyperplasia because there's not really any true hepatic cells in it. And it's usually solitary with identifiable margins. So, and then guess what? It's more common in women. And guess what? It's more common in people that take long-term OCPs. Lesions can shrink or disappear after cessation of hormone administration. So if you stop taking your oral contraceptives, there's a possibility that they could just shrink. They could be asymptomatic or they could cause epigastric pain. Usual sonographic appearance, encapsulated, well circumscribed, hyperechoic mass with hypoechoic halo. Look how pretty this looks. Like, oh, you can see it here, but look how pretty it looks when you put vascular flow on it. It's called the halo effect. So you look at it right there. This patient had severe right upper quadrant pain. And look how, like, it looks not pretty. It looks like it could, it's complex. It looks like it's ruptured. Lipoma, it's very rare, but they want you to know everything. So they do not undergo malignant transformation, which is very good. And they're usually asymptomatic. They're highly echogenic, kind of like the hemangiomas. Here is one. I like these echogenic masses because they're really easy to spot more than those like subtle hypoechoic masses. So like a lipoma, like fatty's going to be brighter, right? And so that's why this is looking like this. So this has the appearance of a possible lipoma or a possible hemangioma. Probably a hemangioma though, correct? Because a hemangioma is the most common and lipomas are rare. Which benign liver neoplasm associated with using oral contraceptives? Well, we kind of talked about the focal nodular hyperplasia or the liver cell adenoma, but it's more common that you have issues with the liver cell adenoma. So D is correct. Which benign liver neoplasm typically presents with a speed error artifact, which helps confirm the nature of the mass? Lipomas, because they can, fat speed is slower because it has to get through all that fat than normal liver parenchyma. Oh. Which benign liver neoplasm histology includes Kupffer cells that accumulate injected TC sulfur colloid? Well, I don't know if you need to know all of that, except that it has Kupffer cells because Kupffer cells are like a normal hepatocyte, like a little normal cell. And so a focal nodular hyperplasia has normal cells within it, just an accumulation. So C. Malignant neoplasm. I should not be singing about this. No. Okay, so their primary liver tumors may originate from hepatocytes or bile duct epithelium. Sonography is excellent modality for liver tumors. Contrast may help expedite obtaining a diagnosis, and often patients have malignancy with unexpected findings of liver metastasis. So a primary malignant tumor is a hepatocellular carcinoma is about 80 to 90% of the primary malignant tumors. The second is cholangiocarcinoma, but I want you to know that hepatocellular carcinoma is the most common. It's like the fifth most common cancer in the world, hepatocellular carcinoma. It could be caused by toxins and diet or chronic liver disease, especially cirrhosis, viral infections, some hepatitis, or the parasitic liver infections. Patients that have glycogen storage diseases are more at an increased risk. But usually in the United States, we have the majority of the hepatocellular carcinomas occur because of cirrhosis, and they're unusual before 40 and most common in the 6th decade. So the incidence is increasing. It's higher in African Americans and Caucasians. Men about 3 times more likely than women to have hepatocellular carcinoma. So the men finally have something that they are more common. So it looks like the benign lesions, women, the man has malignant. Liver cancer is the 10th most common cancer and 5th most common cause of cancer death. It interferes with normal hepatocyte function, which causes biliary obstruction, ascites, jaundice, portal hypertension, and different metabolic disturbances. LFTs demonstrate increased levels of ALP, AST, ALT, or AFP. And they may metastasize to the heart and lungs, but they can also metastasize to brain, kidney, adrenal gland, spleen, and bone. Because the liver, like, supplies everything, you know, and so it's going to spread out. These are the clinical symptoms: weight loss, nausea, vomiting, right upper quadrant pain, splenomegaly, palpable mass, hepatomegaly, jaundice, ascites, pruritus, itching. Diagnosed based on medical history, clinical symptoms, increased AFP, imaging studies, and biopsy. The sonographic appearance is can vary. It could be focal, limited to one area, multiple occurs in numerous areas, or diffuse. So the cirrhosis liver texture is already hypercoic. Hepatic cellular carcinoma is usually hypocoic. Let's see what they look like. Okay, color Doppler is going to have chaotic internal vasculature. So it's going to be just not uniform vascular blood flow through the mass. So benefits of sonography: localize, measure, and characterize. Those should be our motto. for this year. Localize, measure, characterize, because that's what we need to really do. We can classify the tumors, focal, multiple, or diffuse, record affected liver segments. We want to classify the tumors, so we want to know if there's just one focal, multiple, or there's like diffuse tumors. Record affected liver segments, visualize displacement or tumor invasion of like the vessels, document tumors compressing the bile ducts, causing local dilatation, document ascites, regional lymphadenopathy, and other metastatic sites. And treatments are hepatic resection, all of those things, or liver transplant. Here is a 61-year-old presented with abnormal LFTs. The sonographic examination found a hypercoic mass that was later biopsied and HCC was confirmed. The patient had a normal AFP. This 62-year-old woman presented with abnormal LFTs. A hypoechoic mass between the calipers was seen by the ultrasound. She then had her AFP drawn and it returned elevated. An ultrasound-guided biopsy confirmed that this was HCC. This 48-year-old man with a history of alcohol abuse and cirrhosis was sent for sonography examination to screen for HCC. A 6 centimeter heterogeneous mass was seen in the right posterior lobe of the liver, with another mass pressing into the IVC, which mimicked a clot. His AFP was elevated, and ultrasound guided biopsy confirmed that this was a HCC. The color box outlines a large infiltrative HCC in D. Paradoppler shows small tortuous vessels inside the mass. So like what I say about malignant studies, they're going to have more tortuous little vessels. They're going to be irregular. They're going to be hypoechoic. They're going to take in the sound. They're not going to have any acoustic enhancement. Thrombus is noticed in main portal vein on patient with biopsy, proven HCC. Color Doppler flow and spectral Doppler tracing demonstrated an arterial waveform inside MPV. Findings compatible with tumor thrombus. Which clinical symptoms is associated with hepatocellular cancer? A, sharp left lower quadrant pain. B, lymphadenopathy. C, splenomegaly. D, weight gain. So weight loss is one. Nausea, vomiting, right upper quadrant pain, pruritus, splenomegaly, a palpable mass, hepatomegaly, jaundice, and ascites. So C is correct, splenomegaly. Which lab test provides the most significant finding suspected case of hepatocellular carcinoma? And the most significant lab value is AFP. So that's what I want you to know, alpha fetoprotein. It's elevated in about 70% of patients. Liver hemangioma sarcoma or angiosarcoma. And this is a rare, extremely aggressive malignant tumor that begins in the liver blood vessels. It quickly progresses, typically diagnosed at advanced stage, strong association with carcinogens, arsenic, thorotrast, and polyvinyl chloride. Developing symptoms may take decades. Metastasis. After lymph nodes, liver is the most common site for metastasis from cancer. Again, everything has to go through it. So if you have ovarian cancer, the blood is going to filter through the liver. So, it could metastasize there. Metastatic liver tumors are are 18 to 20 times more common than HCC. And I believe that because I have seen so many Mets in patients with cancer. Most common primary cancers contributed to metastatic liver disease are gallbladder, colon, stomach, pancreas, kidney, ovaries, breast, and lungs. So I want you to know that. And the liver is vulnerable to metastasis because of the large blood volume and large reserve of lymphatic drainage. So about 40% of patients with cancer have liver metastasis, which is kind of crazy, you know? I really want to show you what it looks like too. So symptoms may include hepatomegaly, jaundice, weight loss, abdominal swelling, bloating, right upper quadrant pain, abdominal pain, or a patient is asymptomatic. LFT values can be normal. AFP is typically not elevated in Mets. Multiple metastasis with multiple liver masses suggest tumor seeding occurred in episodes, and treatment is removal of the affected liver. It could be all sorts of different sonographic appearances: hypoechoic, hyperechoic, isoechoic, anechoic, both, bullseye or target appearance, or complex. But this is interesting that the kind of how it looks could be because of what kind of cancer it is. So if it's a more hyperechoic, it could be colon or renal cell carcinoma. If it's a cystic lesion, it could be more of a leiomyosarcoma or a mucinous ovarian cancer. If it's hypoechoic, it could be lymphoma or target-like or bullseye lesions. It could be lung cancer. So it's kind of interesting there. CUs help to define and extend a disease that will show lesion not appreciated on grayscale. And sonography is useful, can try to locate, measure, and characterize primary lesions. Can include images of pancreas and kidneys, evaluate upper abdominal lymph and adenopathy, can include pelvis in a female patient looking for large pelvic mass, non-invasive follow-up procedure to assess metastasis for changes in size and appearance. Multiple hyperechoic metastatic liver lesions seen in patient with pancreatic primary. 58-year-old man referred for right upper quadrant pain. The diagnosis of pancreatic head cancer with liver mets was unexpected. So you can see the little liver mets here, those little circles. Those are what mets look like. So they're just little circles within the liver. Here they are again with lymphoma. Which statement is true regarding hepatic metastasis? Sonography is very specific for correlating sonographic appearance of metastasis primary cancer. Hepatocellular cancer is more common than metastatic liver tumors. Nope. AFP is frequently elevated in liver metastatic disease. Nope. The liver is the second most common site for metastasis from cancers from other body locations. Absolutely, yes. Which lab test that provides the most significant finding in suspected cases of hepatocellular carcinoma is not typically elevated in metastatic disease? Like we said, AFP is not. I'm going to quickly touch on this and then we'll be done. So contrast enhanced ultrasound is useful in evaluation focal liver lesions. Without contrast, sonography correctly characterizes focal liver lesions about 60 to 65%. So with contrast, 86 to 95%. Without contrast, sonography is able to differentiate between benign and malignant lesions 23 to 68%. With contrast, it's 92 to 95%. Used to evaluate vascularity, enhancement patterns of lesions, differentiate enhancement patterns from definite for benign and malignant liver lesions may allow for definitive diagnosis without further testing. So the advantages is there's no nephrotoxic contrast, eliminates the need for lab tests to assess renal function before contrast agent is administered. Narrow ultrasound beam allows for improved vascularity visualization. It can be used on patients who are allergic to contrast agents or patients with renal failure. Can perform study at the same time as initial sonographic discovery of lesion and may be used to assist with liver mass biopsies. So a lot of the times a patient would do a contrast CT, but this might be an easy CAT scan basically, but this might be a easier way for some patients. Disadvantages: need an IV, 2 or more people are required to perform the study, and about 3 minutes of continuous documentation. So they observe the blood supply during this arterial phase, portal venous phase, and late phase. So the arterial phase provides degree and pattern of arterial vascular supply to lesion. Portal venous phase, malignant masses do not have portal veins, so are iso-enhancing. Describe liver lesion appearance in terms of enhancement and timing of enhancement. Okay, I'm just going through this because you don't need to know all of this at this. I think I just want you to know what it is right now, and then we can maybe circle back later on. But there's just so much in this chapter. I really want you to zone in on what I told you to zone in. So I think for right now, we're going to be done. Go ahead and read this part, but I'm not going to test you on it as this time. So thank you for hanging in there with me. I know this is the longest chapter we're going to have this entire time, but I appreciate it. I know you guys will do great. And if you have any questions, let me know. All right. Bye-bye.